Welcome to this special episode of Around the Room, recorded on-site at the CRA's 2026 annual scientific meeting in Halifax, Nova Scotia. Hosts Dr. Daniel Ennis and Dr. Janet Pope welcome special guests to bring you a daily roundup of highlights from the ASM. This special episode has been made possible in part by Boehringer Ingelheim. Thank you, Boehringer Ingelheim, for your generous support in sponsoring this episode. The scientific integrity and objectivity of all podcast content is overseen by an independent CRA committee to ensure the highest standards.
Welcome to this special edition of Around the Room. We're coming to you almost live from the Canadian Rheumatology Association annual scientific meeting here in beautiful Halifax, Nova Scotia. Every day of the ASM, we'll be bringing you end-of-day roundups, highlighting the most interesting, relevant, and practice-changing moments from the meeting. And I'm very happy to be joined in person by my esteemed co-host, Dr. Janet Pope. How are you?
Great. How are you, Daniel?
Oh, not so bad. And to help us with our Day 2 roundup, we're lucky to be joined again by the University of Calgary's Dr. Marinka Twilt, who is the ASM Program Committee Chair. Hi, Marinka.
Hello.
And today we also have the University of Alberta's Dr. Mo Osman, who is the Abstract Chair and Co-Chair of the ASM Planning Committee. Hi, Mo.
Hi, how are you?
I'm great. It's really nice to have everyone here. Big, happy family to talk about the meeting today. So let's jump right into a busy day of events, Day 2. Started out with the fun run at 6:30 this morning, or at 2:30 a.m. Vancouver time. That was followed by the outstanding podium presentations. So maybe we'll start with you, Marinka. What stood out to you from the podium talks?
First of all, what stood out was, again, the breadth of people, like the experience level of the people that presented, and the amazing presentations, again, independent of the experience level. I think that was one thing. I really enjoyed some of the presentations that were more like basic science, but still understandable. Sometimes it's not the case. And then the more clinical presentations that were done as well. So just to highlight one was Jamika Shiba, who really talked about lupus. And I think she really emphasized the risk of like cancer in lupus and how we really have to do more research to make sure who is at risk of developing cancer or not. She didn't have the answer yet, but she is getting there. And I think that's the amazing thing. And it also shows the questions in the audience, how everybody is working on it and actually helping each other with, have you looked at this or have you looked at that? So I think that, again, shows the Canadian collaboration as well. So that was one of the presentation that really stood out to me. And then we had Dr. Julia Visha actually talking about SURF and PFAPA, which we were talking about yesterday. So that was nice to have that sort of again, but then a little bit more in detail than what Dr. Stringer did in her year of review. And I'm sure Janet has some to add as well.
Oh, I do indeed. So Jessica Whitfield, it's always great hearing from her. She looked at the Ontario Administrative Data, ICES, and she found a couple things, like I'll tell you what might be a bias, and she's aware of it. But the costs of rheumatoid arthritis are going up, the costs of both disability and for the medications. And in a way, they're skyrocketing since 2000 to 2023. And she even found in the under 65 crowd that might have been working that the work disability was at least 10 to 12%. So what we can't say, because our administrative data in Ontario, the government is the payer of first resort if you're over 65, first resort if you're on ODSP, welfare, low income, stuff like that. But we don't know about the people that would be on the private plans. And if anything, people on the private plans might have just as much or more work disability because they can get access to filling out the forms, etc. And they would have more meds probably. So that stood out. And then there was a study that I thought was really interesting looking at what happens to the B cells when you're flaring. And when a person says they're flaring, at least in rheumatoid arthritis, I think half the time it might be their mechanical back pain or OA or other pain. And about half the time, we've looked at it in the CATCH cohort, early RA cohort, that half the time it really is a flare. But this was showing, and it was lupus this time, but showing that the B cells have changed the distribution and some are activated when a lupus patient is flaring. So I found that, yes, the patients do know, I do listen to them, but here's a biological background. What would have been cool to find out is, a week before the flare, what's happened, because obviously the cells are already revved before the flare occurs.
And that was, I think, Dr. Carol Nasser from Joan Whittier's lab,
Yes.
right? Yeah.
Yeah.
And then, of course, we can't talk about everybody, but Dr. Liam O'Neill and Dr. Maria Wesby also gave, and Nerit Barrett gave really good presentations as well. But yeah, it was really, I have to say, I really love these abstract sessions because they are so diverse.
Yeah.
And they were, again, amazing speakers this time.
And I think I totally agree. I just want to mention that Nathan Barrett, I believe he's a third-year undergrad. So not undergraduate medicine, but undergrad. And his talk was really interesting. So I thought that was quite fascinating. He talked about Siglec-1, a serological biomarker of pulmonary involvement in idiopathic inflammatory myopathies. And so he discussed that Siglec-1 is a cell adhesion molecule on macrophages, the expression of which is induced by type 1 interferon. And his study looked at 87 patients, mostly dermatomyositis, and essentially found that higher serum Siglec-1 levels were seen in patients with inflammatory myositis, and there was a negative correlation with FEV1. This is a possible biomarker of significance that they're going to continue to study. And I thought he did a really spectacular job, especially for a kind of stage of training. I thought that was excellent. Great podium presentations. And following that, we had great workshops. I know I really love the one that I attended, but I'll let you folks go first. Maybe we'll start with Mo. What did you get to see?
I actually moderated a capillaroscopy workshop today, and that was very interesting because there were two speakers, Hein Kim from UBC and also Genevieve Jigger from McGill University. And they gave a really nice overview of kind of the utility of capillaroscopy in rheumatic diseases. But then there were also two video capillaroscopes that people and participants got to play with two systemic sclerosis patients who graciously volunteered. And they actually got to see what pathology actually looks like. And they also compared a handheld dermatoscope, which people realized actually this could be useful, but it's not useful all the time. So I thought this was something that was cool. And one of the participants actually said, I wish you guys did this every year. And the speakers said, honestly, I don't know if that's going to happen. But I started chuckling because I said, I can't comment on this because I'm part of the planning committee.
I think that's a really interesting topic because Dr. Kim works at my center, and I do have a number of patients where they have that sort of undifferentiated characteristic, or there's a concern about the development of an autoimmune disease, but they're not all the way there yet. And in working with her and using video capillaroscopy, we've actually identified some people who we would say maybe they still are classified as undifferentiated, but the information that she gathers is this person really does look like they are an evolving connective tissue disease and can even give some indication of there are some features on this that look very much like systemic sclerosis. We should follow them really closely. So identifying those diseases before they achieve clinical diagnosis, maybe that's my own
And where
sense.
I would think it could fit in, because we don't do it actually at our site. But if you can find with magnification a dermatoscope or even a phone or a little attachment on a phone, if you can already find the abnormal capillaries, then it's like a rule in that we're going to follow this person. But as Mo said, when you can't see that, endoscopy is going to go to the next level and you can find some abnormalities that we can't find with like lower magnification.
Yeah, absolutely. Marinka, did you get to attend any of the workshops today?
Yeah, in the morning I attended the Unmet Needs in Pediatric Rheumatology workshop. I moderated that one, and there were 4 excellent talks from Alicia Tran and Madeline Barron, who are both from Linda Hiraki's lab. And one message that I really took away there is that they actually found that if you have high titer anti-La, then the NLE babies have a cardiac risk. If you have anti-Ro, it's more a cutaneous risk. So it was really interesting to hear that, because I think that helps us with actually counseling patients. So that was a really like a take-home, nice clinical message that you can take home. And then Dr. Michelle Batiste talked about transition, which I think is still very hot topic because we still lose a lot of patients in transition. So she's like developing this transitioning readiness and trying a clinical trial with a transition coach to see if that might help. And then Dr. Diane Mosher talked about Room for You and work productivity and the Room for You registry. So it was a very interesting, very diverse round again of excellent speakers.
Right. Now I have a question. My understanding was always if Rho is strongly positive, particularly I think it's big row, that you really need to follow those moms who are pregnant because of the risk of congenital heart block. And it's interesting that they found law because law is
I'm actually saying it wrong.
Yes,
Anti-row is cardiac and anti-LAS
exactly.
cutaneous. So
Because,
you're helping me to do it right here.
Because law is not a loner.
Yeah.
Law loves to go with row, hardly ever goes on its own, but row can be a loner or a combo.
Yeah.
So I think it's a really high row.
Yeah.
And although it's controversial, some data are suggesting that if a mom's just low row positive, that you probably don't even need to do all this fetal echoes on the pregnant mom for the fetus, because there's a lot of stress with that going on. So it's benign to do an echo, but it really freaks out a lot of moms.
It's a lot of trauma-induced.
Yes.
Yeah.
So anyway, high titer though is I think the take home there. Great, thank you.
Any sessions that stood out to
Right.
you, Janet?
So Liz Volkman, who gave one of the keynotes yesterday, her workshop really again talked about some degree of proven therapies that would be more not Western medicine in addition to Western medicine, but she was able to get into a little bit more of her microbiome research, and it was well received. And I think some of the things that are take home are people in the workshop, it resonated that, oh yeah, I've told my patient about breathing exercises because it's free. Or here's some online resources. So for instance, in Ontario, during COVID, the government realized there was a lot of stress, of course, and provided online resources. So it's workbooks that people can go through on their own that are really, I think they're beyond self-help. They have some proof that you can actually improve your stress. And so the free things, Liz said a lot of people were sharing that, and that was very helpful to the rest of the group.
I can comment on one that I went to. I went to the unexplained lymphadenopathy workshop with Dr. Luke Chen and Alexandra Legg, and it was really quite brilliant. I've seen Dr. Chen talk on this before, and just having it reiterated was really excellent. They went through a number of cases trying to sift through the strange entities we sometimes bump into, such as Erdheim-Chester disease, Rosé-Dorfman-Daytum disease, and Still's disease, HLH. And those can be really challenging diagnoses. Dr. Chen, through some of his work, has used relatively simple tests to try and differentiate these things: CRP, D-dimer, ferritin, and the soluble IL-2 or soluble CD25. And just some really big ticket items. So in HLH, you're going to have very high ferritin, very high CD25, and elevated D-dimer. And the CRP may not be elevated quite as much, more mildly elevated CRP in that setting. Whereas Tafro, you're going to have very elevated CRP. You're going to have a relatively lower CD25, so under 3,000. A relatively lower ferritin, also under 3,000, and a really high D-dimer. And then Stills, you're going to have a high ferritin, a high CRP, and a relatively low CD25. So it was really interesting to see how they walked through those really complicated cases. I really like that. So, of course, we should mention the Dunlop-Dottridge lecture. What were some takeaways that you folks had from that? Maybe I can point that to Marinka.
Yeah, I have to say it was an excellent presentation, and specifically also because it's not as applicable in pediatrics because we don't see that kind of myositis that often, but she still actually tried to make it applicable for us, which was really nice. She actually sometimes did and put in, and what about pediatric patients? So I really like that she actually even was willing to do that. And I'm always surprised that we try to treat our patients, but we're actually doing more harm than that we're doing the good, right? And specifically with those statins, that sometimes even years after statin use, you can develop myositis, and that it can also stick around for so long, even after you stop it, was really for me that I thought, I never thought about that because we don't prescribe that much statins in pediatrics. But I have to say I thought it was a really great lecture, but I'm sure Janet has some more take-home points for her because she probably does see those patients.
We do see them, and sometimes it is difficult to diagnose. So Lisa Christopher Stein, first of all, her slides were impeccable, and she was able, because she is a clinician as well as a translational scientist, she was able to really, I think, give take-homes for everybody of the adult rheumatologist. So IVIG long-term and start early. rituximab if needed. Steroids don't work well, so be happy to move along quickly. Don't do a biopsy early because they'll just have liquefaction necrosis, which doesn't really tell you anything. So if a CK is 80,000, you're going to wait till it cools down a bit. I think also that the other take-homes were really basically clinically, you have to suspect. So we sometimes think, okay, the poor patient has fallen on the floor. They've been lying there for 2 days because they don't have a medic alert or something to buzz or whatever. I think we have to realize that this, although uncommon, is treated differently than basically somebody who's dehydrated and has a lot of muscle tissue breakdown because they're lying on the floor for a long time. So they were my main take-homes. And don't be afraid of triple therapy, which we do use in our inflammatory myositis. So that would be rituximab, tacrolimus, but that steroids really aren't going to work well. And when you stop IVIG, it usually wakes up.
She also made a point that, like, maybe this is obvious to listeners, but to not re-challenge with an alternative statin, right?
It's one shot only. Yes, that was actually very helpful to say.
Once you got the disease, that's it. No more statins. And then thankfully we have other agents, ezetimibe and PCSK9 inhibitors, to maybe do the work instead, but unfortunately it's just a no-go.
And that all of inflammatory myositis, I was always taught it was painless unless if their CKs were like 100,000 or something. And it never rang true when we'd see patients. So myalgias might be even more common in this condition with the HMG co-reductase antibody, but you can get myalgias, and it would make sense to me that even kiddos will get myalgias if they have inflammation in their muscle.
Yeah. I did have to say I really loved one of the questions about the people who get twitching or muscle spasms on like the statins, if that would be potentially an early sign of, and she was quite clear that that was not, which I think is very reassuring, because that's always when somebody is on statins and they say, oh, I have these cramps, and then now I would be like, oh my God, you're going to get myositis. Totally, but now we know that's not the case.
Absolutely. All right, so that brings us then into the afternoon, and there was a really great debate. Mo, did you have a chance to listen to that?
Yes, the great debate is always very entertaining. This year, the great debate was about tapering DMARD therapy versus not. I have to say, I've never really thought about tapering DMARD therapies in patients who are quite seropositive. And I think the take that people had reaffirmed this, which is good. I really remember one particular slide. I wish I had taken a picture, but it was highlighting how all the societies literally do not recommend tapering or conditional in quotations, which I thought was like, okay, at least I've been doing this properly, which I felt good about, but I thought that kind of took it home for me. So I thought that was the highlight there with regards to how things ended and how it swayed my vote.
What were the other takes? Marinka, Jenna, what do you think?
I think what resonated with me as well is what Dr. Guzman said is, if you don't try it, the patient will try it, which is true, because I think specifically in pediatrics, we see that a lot. If you don't address potentially stopping medications, they'll come back and they've done it themselves anyway. So I think that resonates as well. I also think we have to think about, is tapering really tapering to stop? Or is tapering going to be, you're tapering to the dose that they stay in remission and the lowest dose? Because I think there's a difference there, because I think stopping is really hard. And we've seen a lot of patients that then have to restart, and you don't always recapture. But tapering to potentially every 3 weeks of an injection is already a big gain. So I think there's still value of tapering, I think, but we have to realize that maybe we shouldn't do that deep prescribing where we really are going for no medication, but we should go to that lowest dose where we are in remission.
I think as well we naturally do it. So when I'm in clinic and someone says, Dr. Pope, can I lower my methotrexate? I always say, what dose are you taking now? You used to be on 25. What are you taking now? And the trainees think I'm deaf or something. But when they ask, it's because they're asking permission for what they've already done. Yeah. And they tend to know things. I think if we compare it to an asthmatic, if you have a symptomatic disease and you start lowering your asthma treatment, you go back up when you're flaring. So I think patients do that all the time. What is important, though, and that all sides on the debate really made it clear, is it should be a shared decision that we're aware, and to say, if you are flaring, go back up to the previous dose. Yeah. And the chance of not regaining in trials where, let's be fair, where they're watched very carefully, there's some degree of this shared decision-making, informed consent. In trials for not demedicating, but for lowering dose, at least in early RA, 1 and 3 can get away with it, and in established sort of 1 and 6. But as soon as they're seropositive, or if they haven't had a long, deep remission, just don't even go there. But I think the burden of pills or of treatments is an issue for people, and people do vote with their ideas, whether they're evidence-based or not, and they never, 100% adherence is quite rare.
Yeah.
It's actually in pediatric uveitis is the major reason to stay on medications.
Because it's asymptomatic.
It's asymptomatic, and recapturing is actually quite difficult. And they all flare, the flare rate is much higher.
Yeah, I thought it was a really great debate. I love
the pictures.
Yeah.
I was going to say.
And the humor.
Yes.
The 6'7"?
Yes.
Right.
The role playing was great.
Yeah, I really liked Dr. Hazelwood's impression of a youth. That was great. Okay, so then we also had a couple of poster sessions. Maybe, Mo, we can start with you on the poster sessions.
Yeah, so I went to the Basic Science poster tour, and this year it was a little bit different, and I think it actually was better, I thought. So instead of having the traditional poster tour whereby you had posters and Q&A led by the moderator, you basically had the person presenting their poster on a big screen, and the moderator was there, and they had a few minutes to describe their poster and so on. So in this case, it was Dr. Haniel Gebelawi, who's a basic scientist, well-known, internationally recognized basic scientist. And the poster tour session that really caught my eye was actually Liam O'Neill's student, who presented this idea related to how proteases can actually activate the blast-like synoviocytes from, I guess they use osteoarthritis patients, but I think the idea that the serine proteases like PR3 and other things can really trigger that inflammatory environment, potentially through neutrophils, is an interesting one. And it really highlights this added layer in the complexity of rheumatoid arthritis, which I thought was kind of cool.
Marinka, what stood out to you?
I have to admit that I did not go to one of the poster sessions because I had a workshop to prepare and to finalize. But what I did hear is a lot of people already actually reaching out to me and saying that they really liked the new idea of the poster session. So they liked going to the rooms. They liked having the short talks, to giving more people the ability to really give a presentation instead of you're in this cramped area and nobody hears it. So I think that's my takeaway from it. But I'll see if Janet has done a little more in depth.
So one of the interesting ones, Cheryl Barnaby, who's going to win her wonderful deserved award tomorrow. We'll probably hear about that during the meeting. Her investigator award, distinguished investigator. So she was moderating poster tour 1, which was about health outcomes. So first of all, the breadth and depth of what was discussed was actually quite amazing. So they had hospitalizations for psoriatic arthritis. They had workplace accommodation and how it doesn't always work out. They had perceptions of barriers for interdisciplinary rheumatology care and emergency room visits for gout flares. And I think it just tells you that in these unmet needs on health services, et cetera, the breadth of the research going on, there were lots of individual take-homes, but overall as a group, it was just a nice kind of tour to see what these posters were all about.
Yeah, and I think Dr. Barnaby did a really good job creating that preamble for this poster session, which I thought was really helpful to get a sense of where things could potentially be, and the presenters did a fantastic job.
So before we wrap up today, we should, of course, mention that Mo has won the Early Career Investigators Award. Deserved, and really beautiful nomination videos were submitted. So
the most of any person, you had the most nomination videos.
I don't think there's an award for that.
Right, but there could have been. There could have been.
You would have won it.
Yeah,
heartfelt, funny. They were great.
Most popular. So finally, maybe we'll just chat about what you're looking forward to on day 3 So, Marinka, what's coming up that you're looking forward to?
I'm really looking forward to the state-of-the-art lecture because it's by my good friend Mike Umbrello, who is going to talk about Still's disease and adult-onset Still's disease across the age spectrum. So I'm really looking forward to his lecture, and I'm sure it's going to be an amazing one.
Janet, what's on your docket?
I think the podium presentations, again, there's going to be, for instance, Leahy-Etter, so psoriatic arthritis. But you look at the names of the presenters, and we are going to have a really vast array of excellent abstracts. And these are highly chosen when they do these podium presentations. Really looking forward to that.
And Mo, anything on your list for tomorrow?
Yeah, so honestly, I have to say I have been currently managing a patient with ADA2 deficiency in the hospital, and it struck me that actually Dr. Umbrello actually published lots.
That's his wife, Mandy Umbrella.
Oh, is it?
Yes.
Okay.
So Amanda Umbrella, his wife, is like the Data 2 expert of the world. Yes.
Okay. That's cool. So I'm looking forward to actually his talk, and because I actually would like to learn more about how to utilize genomics in risk stratifying patients. I am also looking forward to the podium sessions tomorrow, bright and early. Please come. It'll be really exciting, and hopefully we can see some real primary data that isn't published yet, which is always really exciting. And of course, something that I think I would like to go to with regards to the workshops is something I like to use in my clinical practice, which are topicals from A to Z. So that's something that I love using in my patients with SARDS. And so I'm curious to learn more about those tomorrow.
And me, I'm looking forward to the gala dinner because I like to get fancy sometimes.
Yeah, fancy, dancing, a lot of fun.
Yeah. All right. That's our after day 2 of the annual scientific meeting here in Halifax. We'll be back with one more ASM Roundup at the end of day 3. Be sure to join us for that. A special thanks goes out to our podcast team, Dr. Dax Ramsey, Dr. Janet Pope, Dr. Marinka Twilt, Dr. Mo Osman, Aaron Stewart, and David McGuffin of Explore Productions. Our theme music was composed by Aaron Fawnwell. For more information about the work of the Canadian Rheumatology Association, visit rheum.ca. With Janet Pope, I'm Daniel Ennis. Thanks for listening, and we'll catch you tomorrow.